Hi all, welcome back to Emergency Medicine Lecture Series. In the current video, I'm going to discuss mainly the ACLS principles of managing a cardiac arrest patient, albeit in a different way. I'm going to discuss about asystole and what are the things that you need to do when you see an asystole, also called as flat line, on a monitor. I'm Dr S Prakash Babu, Associate Professor of Emergency Medicine at Karpaganaga Institute of Medical Science and Research, Changalpattu. So first, let's have a look at some of the cases, or let me call them as scenarios, where proper identification and management of asystole becomes important point. The first case, you have a 45-year-old male patient who is a known case of diabetes and hypertension, and also a known case of chronic kidney disease, was presented to ED in cardiac arrest. And the monitor was showing flat line. There are junior doctors who tried to resuscitate the patient. Despite their best efforts, the patient could not be revived. So the junior doctor who is managing the case got frustrated and delivered a defibrillation shock, and immediately the rhythm was restored to normal sinus rhythm and there was an ROIC achieved. So how do you explain this scenario? Any ideas? Let's look deep into it. So when you see an asystole or a flat line in a monitor, the two things you need to remember. One is a true asystole and electromechanical dissociation, which will not respond to defibrillation. The second thing, a VF masquerading as asystole. There is an apparent paradox. Most often, a 5 in VF can masquerade as an asystole. This happens when only one lead is used to monitor the rhythm. Low amplitude fibrillatory waves may appear as flat lines. Or either using more than one lead to monitor or changing the monitoring lead will make VF apparent in this case. So actually the resident was dealing with a case of fine VF which was masquerading as asystole. So even with CPR and adrenaline, when he followed the ACLS protocol, he couldn't revive the patient. But when he used a defibrillation shock, the heart was defibrillated and normal sinus rhythm is restored with ROSC. Let's look at a second case. Here you have a sepsis patient who is being monitored in the ICU. The attending nurse saw a flat line and informed the resident who ordered to initiate CPR. But the consultant ordered to check certain things before proceeding into the asystole limb or the non-shockable limb of the ACLS protocol. Can you imagine what are the things that the consultant would have told the resident to check? These are the things, also called as the flatline protocol. First and foremost thing that you need to check when you see a flat line is pulse. Central pulse, if present, effectively excludes cardiac arrest and thus asystole. But most common cause for this apparent paradox, when the patient is actually having a central pulse, but the monitor is showing a flat line, is due to disconnected leads. You need to check for any lead disconnection. Sometimes monitor may be dysfunctioning, or there can be loss of power to the monitor, which is not picking up the signal properly and showing it as a flat line. Or a fine VF, which was initially there, would have looked like an asystole, and when the monitor got switched off due to power loss, you mistake that as an asystole and you proceed with treatment. And finally, low signal on the ECG monitor can masquerade a fine VF as asystole. There is a specific function called gain function in each of the monitors where you increase the amplitude of the ECG waves that are recorded in the monitor. When you use that gain function and increase the amplitude, a occult VF becomes apparent on the monitor. So you can follow the shockable limb of the ACLS protocol. So what is the frequency of this occult VF? VF masquerading as a systole is called occult VF. Of course, it's very rare. Studies have shown that frequency of occult VF is no more than 8 to 9%. Then coming back, what is an asystole? It is a cardiac arrest rhythm in which there is no discernible activity on the monitor. Or monitor will show a flat line of the ECG monitor waves. What are the causes for asystole? Prolonged illness or a preterminal event. Prognosis is very poor when you see asystole. So let's look at how a fine VF and a asystole look like. In both these pictures, 50 mm per second is being used and lead 2 is being recorded. Look, this is a fine VF and then you have a flat line. A fine VF can appear in a asystole, but when the amplitude of the monitor is increased, fine VF will become apparent. So let's assume that asystole has been confirmed. And what do you do next? Asystole is treated using the right-sided limb or the non-shockable limb of the ACLS cardiac arrest algorithm. Identification of the cause and treating it appropriately is the main step in successful treatment. Although you can use your CPR and adrenaline, always review the 5Hs and 5Ts. So let's have a look at what does the algorithm say. Now the right-sided limb of the ACLS algorithm. First of all, you need to activate emergency response system, start CPR, connect monitor, provide oxygen. Use seeing an asystole or PEA, CPR for 2 minutes. Within the 2 minutes, you need to get an IO or IV access. IV access is always preferable. If IV access is not possible, you can go for IO access even in adult patients. Epinephrine every 3 to 5 minutes is the norm. 1 milligram of epinephrine you give every 3 to 5 minutes. Advanced airway and capnographic monitoring treat the reversible causes. Check the rhythm and pulse every 2 minutes. If you are still seeing asystole or PEA, repeat the cycle. Anytime a non-shockable rhythm, that is asystole or PEA, can become a shockable rhythm, that is VF or pulseless VT, then you need to change your algorithm from right-sided limb to the left-sided limb. That is shockable limb. Initial asystole is found to be VF. You follow the algorithm for a shockable rhythm where VF or pulseless VT is there. Initiate CPR. Defibrillate the patient as early as possible during the first cycle. CPR for 2 minutes. Within the 2 minutes, either IV or IO access has to be obtained. At the end of 2 minutes, you pause for pulse check the pulse, analyze the rhythm, and you switch roles. You are seeing a VF VT now. Prepare for shock. Continue CPR for 2 minutes. So you have completed 2 cycles of CPR and given 2 shocks. Next is CPR for 2 minutes. Epinephrine every 3 to 5 minutes. After 2 shocks, the third cycle you initiate epinephrine. Consider advanced airway and capnographic monitoring. during this phase. Again, in the next cycle you are checking, still it is shockable rhythm. You deliver a shock, and at this stage, that is after 3 shocks, you give 1 dose of amiodarone. The dose of amiodarone in cardiac arrest is 300 milligrams IV bolus, and at this stage you need to think about the reversible causes, try to find out and treat the reversible causes. Still VF or VT is there, the same you will continue CPR for 2 minutes. Epinephrine every 3 to 5 minutes can be given. A second dose of amiodarone at 150 milligrams can be repeated, and there is no limit for number of shocks you give until you see a shockable rhythm. Go on continuing CPR and VF or VT. Finally, it's the decision of the treating doctor, depending on the situation of the patient, whether the patient can be revived or not. But until electrical activity is there, the guidelines say that you can continue CPR. Asystole RPE anytime during the resuscitation, switch to the right side limb of the algorithm. VF VT can be converted to a non-shockable rhythm, which can be treated with shockable rhythm. The mainstay of therapy management of a cardiac arrest patient include appropriate drug therapy, appropriate energy for shock, proper airway management, high quality CPR, team dynamics and leadership, and post resuscitation care. So the drugs that are used in ACLS, you already know, adrenaline and amiodarone are the only drugs that you use for a cardiac arrest algorithm. So epinephrine 1 milligrams IV or IO, give every 3 to 5 minutes or every alternative cycle. Amiodarone 2 doses can be given if you are seeing a shockable rhythm refractory to shock. After 3 shocks, you give first dose of amiodarone. After 4 shocks, you give second dose of amiodarone. The first dose for amiodarone is 300 milligrams and the second dose is 150 milligrams. Appropriate energy for shock. You can straight away use the maximum energy available, the particular defibrillator that are using, or you can follow an escalating protocol where you start at 120 joules and every time you increase 20 joules. Airway management, within the second cycle you need to secure an endotracheal intubation definitive airway if expertise is available. If expertise is not available, you can go for supraglottic airway devices, which are very easy to insert. High quality CPR, again high quality CPR includes a rate. You know the rate is 100 to 120 cycles per compressions per minute. You need to minimize the interruptions, and you need to have a proper closed loop communication. Team dynamics and leadership are very important, which we'll see later, and post registration care is important. During therapy, during registration, as I told earlier, epinephrine and amiodarone, IV or IO 1 milligram every 3 to 5 minutes of epinephrine. Amiodarone, you can give 2 doses, first dose 300 milligrams IV or IO bolus after 3 shocks, and second dose of 150 milligram IV or IO bolus after 4 shocks. Energy for defibrillation. In biphasic defibrillator, usually manufacturer recommended. Initial dose of 120 to 200 joules can be started. You can either follow a single protocol where you go on giving 200 joules every time, or you can follow an escalating protocol where you start at 120 joules and increase upwards. If not sure about the defibrillator type, you are supposed to use the maximum available dose on the defibrillator. A second and subsequent doses should be equivalent or use escalating doses. If it is a monophasic defibrillator, 360 joules is the recommended energy. But if you are not sure what type of defibrillator, whether it is a biphasic defibrillator or monophasic defibrillator that you are using, just turn the knob to the maximum available energy and deliver a shock. Airway management, endotracheal intubation or supraglottic airway device, waveform capnography or capnometry to monitor the ET tube placement, Give one breath every second. Sorry, give one breath every 6 to 8 seconds once advanced airway is in place with continuous chest compressions. You need not coordinate. High quality CPR. Push hard and fast, at least 2 inches or 5 centimeters at a rate of 100 to 120 per minute. Minimize interruptions in compressions to less than 10 seconds. Avoid excessive ventilation. Rotate the compressor every 2 minutes or sooner if fatigued. If advanced airway is not secured, 30:2 ventilation compression ratio has to be followed. In giving ventilations, do not overventilate. One breath has to be given over a period of 1 second, 1 second pause, and then you give second breath over 1 second and immediately resume CPR. Reversible causes and their treatment. First, let us have a look at the 5Hs. Hypoxia. The mainstay of treatment for hypoxia is giving supplemental oxygen. You can use any form of supplemental oxygen that is available. Hypovolemia. Correct with IV fluids. If hypovolemia is due to hemorrhagic shock, you start with blood. If blood is not available, for time being, you can use crystalloids. As soon as blood is available, convert from crystalloids to blood products. Don't use whole blood, use always blood products. And if hypovolemia is not responding to fluids, then you can go for vasopressors and inotropic agents. Hypothermia, consider in case of drowning, check with a low reading thermometer for exact measuring the temperature. Active rewarming is the treatment of choice. Hyperkalemia or hypokalemia, hypocalcemia, acidemia, or other metabolic disorders. ECG may be characteristic in case of hyperkalemia. Give IV calcium chloride for hyperkalemia, hypocalcemia, or calcium channel blocking drugs overdose. Give IV calcium chloride. Hydrogen ions or acidosis. The mainstay of treatment for hydrogen ion excess is IV fluids. 5Ds, tension pneumothorax. Consider if trauma or previous attempts to insert a central venous catheter are performed before the cardiac arrest, and you need to decompress tension pneumothorax as early as possible, and followed by post registration you need to insert a chest tube. Cardiac tamponade, particularly in case of trauma, you need to aspirate the fluid by transcutaneous pericardiocentesis under ultrasound guidance. Toxins or tablets, consider reversal agents based on the type of toxin or the tablet induced. Thromboembolism, it can be either an MI or pulmonary embolism. Consider thrombolytic drugs, but these may take up to 90 minutes to work. And finally, trauma, treat the cause accordingly. Then coming to team dynamics, we're going to follow crisis resource management principles in managing the resuscitation team. Goal is to reduce disorganization and manage everything in an orderly manner. Training in these principles to improve the quality of ACLS performed by healthcare clinicians is feasible and also recommended. Clear roles, leadership, and communication form the basis of crisis resource management principles. So, team dynamics. These are typical ACLS team members and their positions. There will be one person who is expert in airway management for airway management, and there will be a compressor. This compressor and the person managing the airway, every 5 cycles, 2 minutes, they will alternate with each other. And one person starts with managing the defibrillator. This person managing the defibrillator every 5 cycles alternates with either the compressor or the airway management. And this movement of these persons should be in only one direction, clockwise direction, without interposing directions. And then there is a team leader who is the most senior person who organizes all of the activity and manages the code. And finally, there is a timekeeper or recorder who records all the events based on that time, and is the timekeeper's duty to remind the team when 2 minutes is over, to check pulse and analyze rhythm. And one more person for securing the IV access and managing or administering the medications. This forms a typical ACLS team wherein you need at least minimum of 6 members. Team leader organizes the group, monitors the performance of the group, be able to perform all skills, but doesn't perform any of the procedures when the team members are able to perform. He directs the team members, provides critique of group performance after registration effort. Team member has to understand their role and stick to their role. They should not interrupt with others' roles unless specifically asked by the leader. They will be willing, able, and skilled to perform the role, understand the ACLS sequences and the algorithms, be committed to the success of the team. Communication. Usually, a closed loop communication is followed. Order should be clear, loud, and complete. Request to repeat when an order is not clear. Reciprocate loudly when an order is completed. Post cardiac arrest care or management of hemodynamics. If you have not taken a proper history earlier, now we are going to take sample history with specific emphasis on signs and symptoms and the events that preceded or followed the cardiac arrest. Relevant specific investigations to identify and confirm the cause of cardiac arrest have to be performed. Optimize the hemodynamic status with mechanical ventilation, fluids, and vasopressors. Maintain a map of at least 65 millimeters of mercury or higher, or a systolic BP of 90 or greater. Ventilatory management. Titrate oxygen supplementation to a saturation of 94% and above. Do not aim for 100% saturation. If you achieve 100% saturation, titrate the oxygen down. Otherwise, you are going to cause more damage in the form of generation of oxygen free radicals and oxygen toxicity. Always avoid hyperventilation. PCO2 target of 35 to 45 and ETCO2 of 30 to 40 will suffice. Start with respiratory rate of 10 and titrate to the targets. Immediate coronary perfusion. Suspected or proven cardiac ischemia. PCI is the treatment of choice. No contraindications to PCI as such. PCI and TTM can be safely combined together. So always go for PCI. The patient is having a myocardial infarction and goes into cardiac arrest. Coming to targeted temperature management, also called as therapeutic hypothermia, is the maintenance of the specific body temperature goals after return of spontaneous circulation post cardiac arrest to reduce the brain injury. The principles on which TTM is based on is post ROSC perfusion mismatch in the brain, decreased flow and increased metabolic demand are there, along with poor cerebral autoregulation, which can lead to permanent brain injury. When you reduce the temperature, brain metabolic demand, cytokine release, free radical damage, intracranial pressure, seizure activity, all decrease, thus protecting the brain tissue from ischemic and reperfusion injury. Early evidence exists demonstrating that TTM is also protective of cardiac tissue. So what are the inclusion criteria for TTM? All patients post cardiac arrest requiring chest compressions or defibrillation and who cannot follow commands after ROSC are the candidates for TTM. There are no absolute contraindications for TTM. Some of the relative contraindications include pregnancy, traumatic arrest or active bleeding, uncontrolled arrhythmia or hypotension, severe sepsis or terminal illness with less than 6 months expected mortality, poor baseline mental status, and do not resistate orders. So you initiate the TTM, rapidly cool to a target temperature of 33 degrees centigrade as soon as possible within 4 to 6 hours post ROSC. and you maintain this for 24 hours at 33 to 36 degrees centigrade, and then gradually rewarm to increase core temperature to normothermia 36 to 37.9 degrees centigrade, and prevent fever to maintain normothermia for 72 hours. Initiation methods, you can use either surface cooling, which includes ice, cooling blankets, commercial cooling devices, intravascular cooling catheters, internal devices, and devices with temperature feedback have improved outcomes. Administration of cold IV fluids is less favorable than the other methods, which can damage the endothelium of the arteries. Complications of TTM, hypotension and bradycardia because of reduced temperature. Arrhythmias are very common. Decreased O2 requirement due to decreased metabolism, cold diuresis, electrolyte shifts, hypophosphatemia, hypomagnesemia, hypocalcemia, and hypokalemia. Hyperglycemia can occur due to reduced metabolic activity, decreased GI motility, coagulopathy can ensue, and decreased drug metabolism is evidenced. To summarize, follow flatline protocol when there is a straight line in the monitor. Do not rush to initiate CPR thinking that this is asystole. First, you need to check the pulse, then make sure that the leads are connected to the patient and the monitor is working properly. If you have, and check the gain function to make sure that there is no fine VF or occult VF, and then you are going to follow. If it is asystole, you are going to follow the right limb of the ACLS protocol. If it is a VF, an occult VF, you are going to follow the left-sided limb of the ACLS protocol. Delivering shock in a non-shockable rhythm is as deleterious as delaying shock in a shockable rhythm. So remember this. Do not shock a patient in non-shockable rhythm. Do not delay shock in a patient who is in a shockable rhythm. Always try to identify and treat the cause appropriately and also early in the course so as to improve the neurological recovery, ROSC. Appropriate use of drugs, teamwork, and closed loop communication are very crucial for management of cardiac arrest case. Today's talk is not about death, it's about life after death. Thank you. Please subscribe and share these videos for wider dissemination. Thank you once again.